Good afternoon. I'd like to welcome and introduce Dr. Robert Murphy, Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine, who answers your COVID questions every Wednesday on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be answering viewer submitted questions and addressing the latest COVID headlines through today, March 8th. We invite you to submit your questions via Facebook at any Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Leading the discussion today is myself, Seven Bukowski, a student research assistant with the Institute. So, Dr. Murphy, I'm going to start with some updated COVID statistics.
Thank you, Sophie.
In the United States yesterday, 28,808 new cases were reported, with our 7-day average at about 32,000 positive cases, with a 10% decrease over the last 7 days. Hospitalizations have decreased by 11%. The death rate is still increasing a little bit, but every week it's been increasing, and we should talk about that in a second. Illinois' last reported cases were on March 2nd with about 10,000 new cases. Cases are decreasing by about 20%. Hospitalizations are decreasing by 4%. And overall, the death rate in Illinois is also decreasing by 14%. So, Dr. Murphy, I want to go back to what's going on in the States. I feel like for the last 3 or so weeks, I've reported that the deaths are increasing by like 3%, 4%, 6%. Why is that happening? What is going on even though the daily average is decreasing?
Well, the problem is the reporting is not exactly specific and on time anymore. It's the whole COVID reporting and everything about COVID. There's less and less interest, so everything's getting reported maybe once a week, or when they get their stuff together, and that's going to get sort of worse with time. I mean, it'll still get reported, but it's just not getting reported like real time. So the numbers are going to bounce around a little bit. And as I've mentioned many times in the past, and other people talk about it too, especially when you're looking at death, the hospitals are pretty good at keeping people alive, even if they're really sick. So death is always the last metric to improve. When the death rate starts going down, that's like a super good sign that the pandemic is really going downward. Remember, it's not that long ago, before Christmas, where we had daily death rates of about 300. So, we're at, in the mid 400s now. So that's because of the holiday wave that happened, which was much smaller wave than last year. Remember the Omicron wave last year? That was really a big one. So anyway, so that's why people get infected at the end of December, or many more people get infected at the end of December, early January, and then they get sick, and then they're in the hospital, and especially people with underlying diseases and stuff. They have all these problems, and they're getting intensive therapy, and in some cases they die. And so it takes weeks for that to sort of play out, who's going to survive and who's not going to survive. So it's just the tail end of the pandemic. It's still, you have to put it into perspective. I mean, this is now 4.5 times greater than the typical death rate for flu. And that's why COVID is like the third leading cause of death in the United States. That came out of nowhere. Mm-hmm. And so we'll see how that plays off and where this thing kind of goes down to. It's easy to count death from COVID, and it's easy to count hospitalization from COVID or with COVID. And so those metrics will be followed forever, most likely, because it's such a common disease and can result in hospitalization and death. And you'll see that reporting over time, but it's going to become, how we report like flu and the other diseases. So it's just falling into this category of, yet another disease that's trapped. Now, if there's some big uptick or something, if there's a new variant that comes out that starts causing trouble, you'll see, maybe a reinstitution of the more intense counting, but that's, I think, unlikely to happen unless people stopped taking the vaccines. So a lot of this really depends on the public response to the pandemic. You know, there's still the number of people who've taken the bivalent vaccine, the newer vaccine that came out in September 2022, is still very low. And there's really great data that show that it's really quite effective. So, you know, the fewer people that take that, you know, the better people will do in general. And if people just stop taking the COVID vaccines, you're going to see upticks again, because people will lose their natural immunity like they do with the flu. So anyway, that's what's going to happen. And it's just another reminder that people should be taking the vaccine. And if they're sick, they should get diagnosed quickly. You can do it with a rapid test. There's now an approved test that does flu and COVID at the same time. And within a reasonable amount of time, several months or a year or so, we'll actually be able to test for at the same time on the same like little card that you're going to pick up in the pharmacy. You can test yourself for COVID, flu A, flu B, and respiratory syncytial virus. So all 4 of the big respiratory pathogens. So that's kind of the story right now. So it's kind of slowly bumping along, and we expect the death rate to drop at some particular point in the next weeks or months.
Yeah, I hope so. Well, following with everything that you just mentioned, our first headline is that long COVID patients are more likely to have gastrointestinal problems, a new study is finding. What can you tell us all about this, Dr. Murphy?
Yeah, this is actually a really kind of good report. I mean, a very informative report. This comes from the Veterans Health Administration. So that's a nationwide hospital network that provides free care to veterans. And so it's they had one of the first electronic databases in the United States. And they've got all the information. If you're a veteran, you go into a veteran hospital anywhere in the United States, all your medical information is there. And it has been for a long time. So what happened with the Veterans Administration is that they compared the medical records of 154,000 COVID patients. And they compared it with 5.6 million patients of a similar age and other characteristics. So it's a matched control group. And what they found was that the COVID patients were 36%, or about 1/3 more, likely to have long-term gastrointestinal problems than they had before the infection. So new gastrointestinal problems. We don't normally talk too much about gastrointestinal issues with COVID, but people reported, but it's mostly all this upper respiratory stuff. But anyway, and they found there were all sorts of problems with the digestive system, including gastroesophageal reflux disease, peptic ulcers, and other kind of forms of gastrointestinal stomach type problems. They think that one possible cause, they don't really know the exact cause, is that the virus attaches to these ACE2 receptors, and some of them are abundant in the small intestine, and that is actually triggering either the inflammation from that, or the virus itself is triggering some of the problem. And another possibility is something they call the gut-brain connection, explaining that when we're stressed, we have intestinal manifestations. So the COVID and the inflammation about the COVID causes this disconnect. And it could also be just because of a general state of being unwell, having other underlying diseases, and that's all having an impact. It's probably a combination of all those things, but I think it was interesting in the fact that how great it was, 1/3 in this population. Now, veterans tend to be older, tend to be males, but I mean, that's just a trend. So it's not a real snapshot of the entire population of of the United States. But it's a very valuable source, and they're looking at millions of people to come up with these conclusions. So the data is very helpful.
Right, right. Well, going into our second headline is that the US plans to lift COVID travel requirements for travelers from China. So, what can you tell us about this rule that was instated, a couple of months ago?
Well, yeah. So China, went from zero COVID policy to, hey, whatever happens, happens. And they had all these, basically everybody in the country got infected. And they've had, tens of thousands of deaths from COVID because of this change in the policy, but that peaked. So the Chinese officials reported in mid-January nearly 60,000 COVID-related deaths since early December, and that the emergency peak from stopping all those controls has passed. It dropped down from 60,000 over a period that they were looking at to 36,000 deaths a day by the end of January. And so, they're coming off their peak. So, and that's why the US plans to lift the testing requirements for people from China because the rate has gone down so low. So we know that testing before you travel internationally is very helpful. It'll cut the amount of cases imported into the country by over 50%. So, China's now just kind of like with everybody else, and everyone else has to just, if you get sick, we're at the endemic stage now, test yourself, get diagnosed, and if you're eligible for treatment, take the treatment.
Wonderful. Well, going into our first COVID question, can you talk to us about, what are some of the side effects that people are suffering now with the updated booster? And should individuals be worried about getting their booster shot?
Yeah, so the side effects really haven't changed. The Omicron variants are, in general, milder than the Delta and other variants of the disease. But the common side effects from the booster anyway is fever, headache, fatigue, some pain at the injection site, and those are the very common side effects from vaccines. And they're self-limited, they're usually gone in 1 to 2 days, and everything resolves. Of course, for younger people, and this is approved for kids now, under 18 in particular, remember, it can cause myocarditis or pericarditis, an inflammation of the heart muscle or the surrounding of the heart. And they have been reported through this VAERS system, VAERS, it's a voluntary reporting system to the FDA, some 715 reports. And so they have the information to fill out a VAERS report. You have to put the age of the person and how they were diagnosed. The FDA follows up to see if they really meet the definition of myocarditis. And so they found, for instance, in 5 to 11-year-olds, 23 verified reports of myocarditis after being vaccinated. That's out of 23 million plus doses administered. So that's 1 per million. Now, as you get older, the number jumps up. So 12 to 15, there were 376 reports out of 25 million. So that's approximately 1 in 70,000 doses. And then from 16 to 17 years of age, there was 316 out of 14 million doses administered. That was 1 in 45,000. It was interesting in this report that they didn't report any deaths. Normally, this inflammation resolves on its own. Sometimes it does require hospitalization. It can be very scary if you're the parent and the kid has chest pain and all this. I mean, it's not to be taken lightly, but there were no, no deaths anyway reported. And so we're presuming then that most of these cases resolved completely on their own, because if they died, they'd fill out another report and that would show up on the death rate. So, so that's kind of the story on the side effect of the vaccines. It fits in with pretty much all the other vaccines that are out there. Every vaccine has some potential side effect with it, but the consequence of not taking the vaccine is there's even more side effects. There's long COVID, there's plus the disease, plus hospitalization, plus even death. Granted, not so much in children, but there were still children who died from COVID. So, you always do this risk-benefit ratio, but I mean, by far, vaccines, keep people healthier and save lives.
Yeah, absolutely. And then I think those were all of our COVID questions for today, Dr. Murphy. Thank you very much, and we will see you next week.
Okay, thank you very much, Sophie.